cette introduction et ce panorama des différentes techniques et différents appareils qui sont disponibles au sein du service. Et avec le docteur Anne-Claire Aurore, qui est médecin pathologiste au sein du CHU de la Guadeloupe, dans le service de Dr Diediou, mais également médecin coordinateur au centre de coordination des dépistages des cancers, qui va m'aider dans cette présentation. Et moi-même, qui suis Vincent Letonc-Savane, également pathologiste au sein du service du Dr Diediou. Nous allons vous illustrer au travers de cas didactiques notre pratique. Voilà, donc je commence tout de suite rapidement avec quelques renseignements cliniques.
Start quickly with some clinical items. Male, 52 years old, who was complaining about backache for 4 months, and his father had prostate cancer. About his biological exams, he has a very high PSA rates, above 969 nanograms per milliliters. So there is an irregularity of the bladder floor, bladder or prostate. There is a diffuse induration of prostate. With this irregularity of the DRE, we did a PET choline and TAP TDM, and these images show the prostatic lesion likely to invade mesorectum, lymph nodes involvement in iliac and mesorectum areas, as well as metastasis in the bones. By the end of this seminar, you'll know these slides by heart. You see a lot of lesion on the skeleton, and you see here all the various black spots showing the metastasis. You see here the images of TDM and fusion images. You see here an image that corresponds to the symptoms of the patient that was complaining from backache, but with a hyperfixation fixation around the vertebrae, which is actually a lesion showing on the standard images. And also, if you see the lymph glands, they have been shown here. There are irregularities with a high rate of PSA. We had an indication for prostatic biopsies done with 12 biopsies, 6 on each side, that will be transmitted and fixed with formaldehyde. Then we produced some blocks fixed in paraffin, and also you see here, this image comes from a digitized slide scanner, which is a Leica machine, and you see here a biopsy sample totally invaded by the tumoral process, showing which is replacing totally the normal glands. About the prognosis factors for this prostatic tumor, we see here a nerve which is
et les glandes tumorales prostatiques. So they're molded around the sheath of the nerve. Another factors that we need to include in the report is the invasion of the adipose fatty tissues that we see here. in white. All of these are adipose cells which are invaded by the tumor. And we can see here nervous sheaths, extra prostatic sheaths, which induce wrong prognosis and show the aggressive behavior of the tumor that comes out of the sheath. This report is given in a very standardized manner on the table. You can see the left and right lesions that were observed for each of the biopsies, the size of the sample biopsy, the size of the tumor, if there is, and the score of Gleason, and the grade percentage. We also show the invasion diagnosis, and with the invasion or not of the periprostatic adipose fatty tissues. So it is a standardized detailed report which can be produced in English or French and which follow international recommendations. Overall, for the patient, it was adenocarcinoma of the prostate with maximum Gleason score of 8, 4 plus 4, with histologic patterns, which is called cribriform patterns, with the perineural invasion and also the involvement of the periprostatic adipose tissue, which shows very advanced behavior. So the aggressive behavior of the tumor, the age of the patient have led us to a prognosis of gene predisposition, and mostly on the BRCA1 and 2 mutation genes, which are studied in biology, molecular biology, from blocks with the tissues in formalized tissues or scanned, which allows for personalized prognosis or diagnosis for each patient. So all these results are provided here, produced here, with a complete analysis of the BRCA1 and BRCA2 of the and that's what these genes show. They show deletion of several exons that lead to a non-functional protein, and that mutation is classified as in a category, in 5 category class, which shows the pathogenic sensitivity or sensitivity of this tumor to a PARP inhibitor, which have been indicated or preconized for this type of treatment of this BRCA. Last news, the patient were doing quite well with no pain and no activity limitation. So I'm going to leave the floor to Dr. Aurore, who is going to show a second case which we use in our daily practice, and the panorama of detection in the service. Good morning to all and one and all, and thank you for your introduction, Vincent. I will start to say that I'm honored and proud that I am the only female, the only woman in that medical team, but I need to tell you that the logistics team is 100% female. So we're going to the second case. A woman, 80-year-old woman who had childbirth, and she went through menopause at the age of 50, and because she had gynecological bleeding, that's what we call metrorrhagia, postmenopausal metrorrhagia. We had an endometrium thickness of 18 millimeters, which is quite thick. There was also an hysteroscopy, which is an examination, a test that allows us to see the mucosal hypertrophy and measures that in the uterine cavity. So we have an endometrial biopsy, which is performed at home in Guadeloupe, informal. So the patient went through an MRI test, which shows the MRI shows the involvement of the cervix, but also the presence of multiple lymph nodes, and mostly with a lymph node of 18 millimeters on the left iliac Herschel area. So this is, in fact, the biopsy, the endometrial biopsy, which was made within paraffin by the technicians in our service, and we reach a stained H&E stained slide. The slide goes through a slide scanner, and that's where we have the digitalized scanner. There is a protocol, pre-analysis protocol before reaching that level, and it is very important. And let me remind you here that pre-analysis allows us to have a better prognosis. diagnosis. So here you can see that these are glances. These glances are fused with marked, and they lead to carcinoma, and this is really what we call an endometrioid carcinoma, which is going to be graded according to WHO as 1. You can't see no vascular invasion, and because the myometrium is not represented, we cannot assess the presence of any invasion in myometrium, and we cannot go into the range or the spread of the tumor. So in our service, we use antibodies which are validated, and they're all from Firoche, which is a very important lab and well-known, famous in the world of antibodies. So here we have a nuclear marker, which is diffuse. I don't know what happened. Oh, here we go. Thank you. So we can see a nuclear markers of on the tissue, which is very strong. 95% of the cells are stained. So there is in the center internegative. So this is the estrogen receptor here. It's the same with the progesterone receptor. So we have a very strong marker, and it shows the progesterone labeling on 99% of the cells. Here it's the P16 heterogeneous cell, because we have discontinued dying. So heterogeneous, we use that term here. So all of these serve as antibodies. These antibodies will allow us to confirm the diagnosis of carcinoma, endometrioid carcinoma grade 1. So as I said earlier, these antibodies come from the Roche biosystems. They are validated with external and internal controls to secure interpretations, and they are compatible with digital pathology of the as H&E slides. We're going to another type of antibody, and that's the P53. These are prognosis tumors or tests, which will allow all these oncologists and nuclear pathologists to treat and study these markings. As you can see we have about 60% of the cells that are affected. So the P53 will have a white phenotype, and then again we'll have 4 antibodies: MHL1, PMS2, MSH2, MSH6, which are part of the MMR system, for mismatch system, which allows us to have microsatellites abnormalities. So, as you can see here, that there are 2 deficient antibodies. They work in pairs. So you have 2 that are deficient, MLH1 and PMS2. We can see that they are deficient because the antibody is positive, and the second group is at the bottom, and they have a nuclear labeling very strong, very high, because we have and also we have a control that is very positive. With these 4 proteins, we will generate a status, and so that we can have a status. Yes, and this patient, we have an MSI diagnosis, because that's how it is called in English, because we have a deficient marking. So they define category of the molecular biology. Yes, so this MSI has to be confirmed in molecular biology, because it is sometimes negative in molecular biology. So here it's not the case, but as Dr. Dieudou said, the partnership is done with Bordeaux in France, but we hope that tomorrow it will be done in Guadeloupe, because these tests are done routinely, and it's very important, it's paramount that for these cancers, endometrial and breast cancers that are done in Bordeaux, and we hope that it can be done, and it is very important that it is be done in Guadeloupe. So we're coming back to the case, the status being confirmed. We look for hypermethylation, which indicates the sporadic character or hereditary character of the tumor. So the hypermethylation, which indicate the sporadic character, once again, contrary to the hereditary syndrome that is linked to Lynch syndrome. So what we could answer to the oncologist at the General Hospital is that some of these grade 1 endometrioid carcinoma, MSI, will have a sensitivity for immunotherapy, which will be discussed in MRCP. So we have here the last classification from the WHO, and we try to implement, to apply, to have all the tests in the right order, so we can have a very personalized medicine. The sensitivity and the MSI status confirmed would confer the patient sensitivity to immunotherapy, which should be discussed in multidisciplinary meetings. And the last we know of the patient, she's alive and under treatment. As a summary, to come back to the question we asked at the beginning, and also to add to what Dr. Dieudou said earlier, what we can provide to you and what we can do together practically is through digital pathology for HNE and IHC, which is so we need to have validated antibodies with controls, external and internal. So we also follow, we have a detailed report according to the latest international recommendations from WHO, ISUP for immunopathology with the prostate, bladder, testicles, and also the recommendations, North American recommendations, US CAP. for Canada and the US. The feasibility of, the deliverance of the reports in English is easy because we have them already. It's easy. It will be even easier for us to have them in English than in French because they are standardized. That won't be a problem. And we will attempt, and that's what we do every day, to have a personalized case by case study so that we can reduce the costs, because health is a business, but it's also true that there are people behind who pay for it, so we don't need tests for several tests. We just need to be very specific, and so that we can have an access to molecular biology in France. That's what we have right now, but we hope that later in the future, in the near future, at the end of the day, we can do it here in Guadeloupe for most of the tests and examinations. And what I'm thinking about mostly is to be able to discuss of these diagnoses with our colleagues from the Caribbean, whether they are pathologists, oncologists, surgeons, those that take care of these patients. And we call that MRCP in France, but these are multidisciplinary meetings. They are called like that in the legal field, but we could have them in a more fluid manner, quaint manner with our Caribbean partners. And thank you very much. Here I'm not talking about anymore as a pathologist, but I'm going to talk as the coordinating doctor for cancer screening in Guadeloupe. It's a center which is financed by the Social Security and also the health agency, ARS. And screening, we talked about it earlier. I wasn't able to talk because it was quite difficult, but it's quite complicated. Screening is quite complicated because screening must adapt to the population that is screened. And we are fortunate here in the French overseas territories to have organized screening, which is about 3 cancers: lung, colorectal, and I forgot the last one, I'm sorry. So these screenings concern mostly patients who are not sick. Screening means that these people do not have any symptoms. So it's not very easy to convince people who have no symptoms to come and be screened at hospital. And in Guadeloupe, and I think Martinique also, but I'm talking about what I know. In Guadeloupe, St. Martin, St. Bart, screening is done on technical platforms, but mostly private ones, because patients, mostly female patients, for breast cancer, for cervix cancer, the patients have better access to private clinics or hospitals, because all populations have their way to perceive cancers and screening, so it's quite difficult to localize, to target screening only at hospital. And that's why we hardly can have one way to screen, one type of screening, because we have to have a personalized screening depending on the population to which it is addressed to. So in terms of prostate cancers, which affect mostly men are not really ready to go towards consultations, because more than women. So it's true, men are not very susceptible to screening, mostly for prostate cancers. So there is a hindrance, I would say, an obstacle. So that's another one. So screening is very complicated, and we need to talk about what we want here in Guadeloupe, because each screening we don't have the same numbers or ratios than in France. So implement a screening campaign is difficult. Breast cancer has been organized for almost 20 years, and here in Guadeloupe we still have some kind of hindrances. And cervix cancer it's in French national terms. It started in 2019, and we are 1 year from the deployment here, the complete deployment here, and we are at the beginning because it had started a year and a half ago. So the transition relies on collaboration. So being able to better treat, better treatment, yes, but we also need better screening and better diagnosis rely on the technical platform also with the support of our authorities, but we also need better collaboration with you and the pathologists of the Caribbean to move forward towards a better diagnosis. So being able to lead better diagnosis and better screenings. Thank you so much. Thank you. Thank you, Dr. Anne-Claire.